Well, welcome everyone. Welcome to the Eyecare Experts, Dr. Bell, Dr. Terrezza. We appreciate you guys tuning in. A good topic today, which will cover a lot of different things. Visual field testing. We want to talk about it, how you would use it, what it shows, the importance of it. And it's related to a lot of things we've done in the past as far as podcasts, glaucoma and stuff like that. But we just want to talk about it by itself because we certainly realize the importance, at least to us, that it brings. But before we get into that, I want to kind of say congratulations to you. Certainly this is our 50th episode, so it's kind of a big deal for us. We've been doing this for, I think, almost 2 years, and I've certainly had a lot of fun along the way.
That congratulations goes two ways. Yeah, I did them with you. Before this, we had a radio show in the mornings on, it's the oldest, WCOA.
Mm-hmm.
And we had good response on that, and that sponsored, or that developed into this. And we will molt from this soon, but we'll tell you more about that in other episodes.
Yeah. Love the radio. This way we can kind of do our own individual thing and have some control. Put it on our website with certainly questions that we get asked, topics that are important, cutting edge equipment. We're always trying to stay on top of things and to kind of make that available for patients and just education in general. I think that's the, day to day we want to see patients, but I mean, that's what we're trying to do every day is educate the patients we see, educate family members on certain conditions, how to best take care of the eye, get them to see the best health-wise. All those things kind of go together, at least in our eyes.
Especially in primary care because you cover all topics. So you got to know a little bit of this, a little bit of that, a little bit of that, and so you can make the right judgments and the right referrals and solve a lot of problems.
Well, we just came back from a good conference in Sandestin, CE conference, and we talked a little bit about visual fields, and I know one of the things they said that kind of stuck with me is the eye is basically an extension of the brain and spinal cord. And we get into visual field testing here in a little bit. I think you guys will kind of understand why, as far as how it relates, how things that affect the brain, certain, maybe the occipital or frontal lobe, and how just running a visual field, we can tell, where it's located, where the tumor is, the aneurysm. To me, that is, it's so cool to be able to tell that just by running a visual field.
Yeah, I had a patient today who, elderly lady, and she was having trouble with her vision. So we talked, and she didn't even mention this to the pretesters or on her entrance interview. And she said, yeah, this has been a rough year. I've had two strokes. Well, when you cut off blood supply to parts of the brain, those parts cannot function well, and generally strokes will botch up your side vision. So her straight ahead vision was good, but when I ran the fields to test her side vision, they were off, and now she was aware of it and now knew it. So even that in itself did the patient some good. And also when she turns her head, or knowing why she has to turn it because she doesn't see to the side. And so I felt like we made some progress with her.
Well, we've been doing this a while as far as at least optometry in general, and I know a lot of my colleagues, they always say, and I think most of them would still say that if they could only have one machine in the office, a lot of them would choose the visual field because of what it shows and the importance, being non-invasive, painless, to be able to run tests and pick up certain things. I still like the OCT. It'd be hard for me to get up to the OCT, but the visual field certainly is beneficial.
That's a hard call. But now there's newer versions of this machine. We have, so in medicine, a lot of, once a test becomes standardized, it's used all over, actually this one's used all over the world. And it's very hard to leave that for newer technology. But the newer ones are virtual reality, and they sit on your head like a headphone, like you're playing a game like the young people do. And gosh, they're very, they compensate. The patient doesn't get as tired when they do it. It's found to be even more accurate, although that has to go through its paces and get triple checked before it's considered the standard. But, for legal purposes and everything else, the only one that's recognized is by a company called Humphrey. Mm-hmm. And they're very expensive, and they're hard to do, and all our offices are equipped with those, I might add.
Well, I guess, and this, I'm just going to go off the top of my head as far as when do we run visual fields? You know, what would be a reason to run a visual field on a patient? Certainly the biggest at the top of the list is glaucoma, to kind of measure visual loss if glaucoma progresses. But even retinitis pigmentosa, if you had a stroke recently, an aneurysm, a tumor, vascular infarction, something like that, you know, we always want to run a visual field to see, hey, have you lost any of your peripheral or side vision? And if you have, we want to monitor that over time. I usually, when I talk about visual fields, with patients, I'll say, it's like checking your blood pressure. Well, one reading is important, but you always look at it over the course in the series. So when I run a visual field, that's great, but certainly we want to repeat it, and we want to watch the course to see, hey, are things changing? You know, is it staying the same? Is it stable? To me, that's what we're looking at over time.
And even though stroke could be considered a form of trauma, but, you know, I had a kid this week in Milton who was playing baseball, and somehow this other guy was swinging a bat, he wasn't aware of him, and the bat hit him on the side of the head. Well, that eye has to be checked for neurological implications of that, and is, you know, the visual system runs from the eyeball in the front all the way to the occipital lobe back here. In fact, it's 27% of your brain mass is occupied by neurons that have to do with the visual system. So I had to run a field on him, and luckily he was in good shape on that.
Well, even just as you were talking, I was thinking of even patients who have dermatochalazias, drooping of the upper lids. You know, we have to show that it blocks their superior vision with a visual field. If they're potentially going to have a BLEF done or medical insurance to pay for it. Sometimes we do screeners for certain licensed pilots, certain things, operating heavy equipment. They want to have a full field, even with a normal driver's license. If a patient, you know, is to a certain degree as far as what they can see, they want to make sure their visual field meets a certain criteria so they can drive.
You can lose your license like that, yeah.
And so, you know, central vision is important, and that's when we read, you know, our macular, our fovea vision, and that is what we probably use most day to day and we rely the most on. But certainly everything outside of that, periphery vision, you know, when you're driving, cars pull into your side, somebody throwing a baseball at you, anything like that, the side vision is equally, you know, is important. And it's one of those things you kind of take for granted. I think a lot of times, and until you start losing it or you have a condition where you're losing it, you realize how important that side vision is.
And don't forget drugs. So there are certain drugs that affect the visual field or how you see in certain areas. And when you run that test, you can pick up if the side effect of that drug, the famous one, is Plaquenil, which is used for arthritis, rheumatoid usually, but other types also. So the way to pick that up is with a visual field.
Pituitary would be another one, especially pituitary issues, pituitary gland, pituitary tumor, maybe at the optic chiasm, stuff like that. Thyroid issues, these are all things that we're looking for, and where we would run a visual field a lot of times on to kind of check that. But Plaquenil is certainly a big one as far as that. Different types of fields. You know, I think when I first started, we ran pretty much a visual field 30-2 for most things, including glaucoma. But that has changed, I don't know, maybe last 15, 20 years, something like that, where we've gone more to a 24-2 because it's a little bit more user-friendly, doesn't take quite as long for the patients. And I think most would argue that a 24-2 with a glaucoma patient gives you about as much information as you need with a 30-2. But now we have the 24-2C, which I think is a good combination. And that 24-2C visual field, Humphrey, it gives you an extra 10 points in the very center to detect early central vision loss. And so a lot of optometrists, ophthalmologists are running that 24-2C, especially with early glaucoma. It gives you a little bit more data in that central vision.
That's why this is a game, and the earlier you detect just about any disease I can think of, it's much easier to avoid long-term damage to the system. And so, because loss of vision is so debilitating, both to the psyche and to the ability of the patient to go on with their lives, that the earlier you get this and the earlier you treat it, the better off you are.
Well, I can remember back even when I was doing my externship right out of school, like what, '03, '04, and I was at the VA in Tuscaloosa. We did pretty much an FDT on every patient that we saw, visual field wise, because at that point, and you know, that was one of the visual field tests, a little bit different than Humphrey visual field, but to check any early at that point, that was, they would say that's the earliest signs you could see a patient who had glaucoma or visual field loss was running with an FDT. I remember doing that.
Yeah. FDT stands for frequency doubling testing. So you can see something shimmer quicker in the certain fields of view. Animals have that. For instance, a deer has very good peripheral perception because it has to, so I can see its enemies from the side a lot quicker and a lot better. And we evolved with that also for the same reason, or so is thought.
Well, back to the Humphrey visual field is the one most of us have, you know, certainly monitoring. That's the gold standard, I think we could say, with glaucoma and a lot of other medical conditions. In the old days, you know, you have to put the patient's prescription in there. And with the Humphrey visual field, you're really putting the patient's near prescription. So with an FDT, I think it's their distance prescription you use. So it's a little different there. But with the visual field, so with the old days, we'd have to put the trial lenses and figure out what the patient needs to see up close. But now, some of the newer models have crystalline lens. It's a lens that you just kind of input what the patient's prescription is, and the lens kind of mimics that and just kind of turns to their prescription, which I think is pretty cool.
It's amazing.
Versus having to put the actual trial lenses in place, especially for patients who have a lot of stigmatism or something like that. It makes things a lot easier. As far as tips using that, so a lot of patients are saying, man, I had a visual field run last year, or maybe I've got one coming up in a couple months. The tips that I always usually use is you have a center fixation light, and you want to look at that center fixation light the whole time. I know it's tempting to kind of move your eye around a little bit and kind of look at the lights that are flickering, but it gives you 3 or 4 chances to get that light. So don't feel like if you miss it, you messed up. You're actually better off just looking straight ahead at the fixation light. Try not to move your head or your eye around, and it'll give you a number of chances. And certainly you're going to click the clicker if you think you see any of the lights flashing anywhere in your periphery. Blink, make sure you're blinking normally. And most of these tests we can pause, so on the second eye sometimes patients will get tired, have issues. If you're certainly like that, just let the tech know who's running the field, and certainly we can pause it, give you a break, because we want the best results that we can get on it.
Yeah, most of the newer models that I was talking about, like for kids and for older people who can't concentrate that much, they can move and blink and do whatever they want, and that is negated by the fact that it's just it looks like you're staring at stars in the night, and it doesn't matter where you look, so you're less likely to make an error.
Well, let's go to some questions. I have some questions here. Basic one here, we talked a little bit about it. We got some flies coming around here. Can a visual field test detect glaucoma? How would you answer that?
Well, it's a rather late sign, so by the time you show up with a loss, so remember, so it's kind of like a house, okay? So if you go in your house and you hit circuit breaker number 7, the lights in your bedroom are going to go off. And if you hit circuit breaker number 5, the lights in the kitchen go off. So you can tell from where the loss is what part of the visual system got damaged. And once you damage it, unfortunately, you can't get it back, at least not currently. Now, they're working on that, but that's another issue altogether. So it's a late sign. Once you figure it with that, once you find it with that, then you've got to get treatment underway in a hurry, because you'll lose it.
No, I think you're spot on. I mean, a lot of times if we're seeing patients regularly and we're looking at the nerve, we're checking their eye pressure, we're looking at photos, we're running potentially OCTs and other tests to determine things. That's the goal, is for us to catch these things, with glaucoma being one of them, especially in this question, is before it becomes a visual field defect. Because once you lose that vision, like you said, you're not getting it back. So, there are patients that get sent to us, referred to us. Maybe we see a patient that just moved from another area, and maybe they already have visual field loss, and we can't go back in time and save that. But certainly the goal with any patient is to catch them early enough or to spot things early enough where we say, hey, your eye pressure is a little bit too high, or hey, maybe there's a little bit of thinning in the nerve fiber layer. Well, let's start you on this drop, or let's do this surgery. So hopefully we lower the pressure with glaucoma, and you never get to the point where you lose that visual field, that vision loss, side vision loss.
For the lay people out here, there's 10 layers to the back of the eye. And so the eye is round because it's filled with fluid. If that fluid, in most cases, if it gets too high, it smushes the 10 layers. This OCT he's talking about is a very sophisticated instrument that measures the thickness of each of those 10 lenses and tells you if there's any problems with that. And we have those at all our offices.
Here's a tough one here. This is, what is the most common visual field defect that you notice in glaucoma? I can think of 2 or 3, but I think the true answer is a nasal step is I think what they're looking for. But with glaucoma, nasal step, paracentral scotomas, and also arcuate. You remember arcuate? We always talk about arcuate-like defects. The tough thing sometimes with glaucoma and visual field is you can have glaucoma, but you can have other conditions as well. So sometimes we have to kind of determine, is the visual field loss due to the glaucomas or something else? They have diabetes, they have other things, so sometimes it gets a little tricky. It's not as black and white as, hey, this is all glaucoma, but that's part of our job is to try to determine, what's causing the issue.
Well, people are under the mistaken idea that if something's wrong with my eye, I'm going to have a symptom, something's going to show. Glaucoma is the classic case where none of that will show. And your brain will fill in the areas. Let's say you lose this thing he's talking about, the arcuate. So it's a semicircular loss that goes from about the hemisphere, the 180 line, up to and including the 90. But your brain will fill in those areas to help you along, thinking it's helping you, just like if you put on 60 pounds and your heart beats much quicker, you feel fine, but your ticker's working over. So your brain will fill in those areas so you don't hit a truck when you're driving. Your vision won't be as good, but you'll get by.
Yeah.
So that's why you need these tests to find that out, because your system is in fact trying to help you and in fact hurting you in that sense that you didn't detect the disease earlier enough.
Well, we appreciate you guys joining in, and hopefully you can tell by the way we're talking about this that visual field is very, very important to us. It applies to a lot of systemic conditions, a lot of things that we deal with day to day in the clinic, and it's a very important tool. We have a visual field at every office, and if there's any questions about it, certainly let us know. You can always visit TerrezzaOptical.com. If you need to be scheduled for an exam or any testing, we'd love to see you. Certainly, the good thing is we're medical. We do certainly vision and glasses, but I think this is the part that really gets us riled up and we really enjoy is helping patients with their health, making sure they maintain vision and don't lose vision over time.
This is what differentiates us from a lot of the other people that engage in the optical industry.
Well, thank you. Again, 50th episode. Appreciate you guys joining us. Until next time, Dr. Bell, Dr. Terrezza, thank you.
Thank you.